My name is Christopher Hartman. I'm going to be doing this case presentation on the knee. Our patient is a 12-year-old male who's right-handed. He enjoys riding bikes around his neighborhood and I guess simply just being a kid. His initial evaluation was on January 29th of 2013, and he had a referral from the physician with the diagnosis of bilateral knee instability. His chief complaint was he wanted to feel more steady with activity and participate in activities without limitations. He reports patellar dislocation 17 days ago and now has instability and given away in that left knee. His date of injury was January 12th, 2013, and the LEFS score that we received was 60. Our predicted number of visits is approximately 16 visits. And the predicted length of the episode is 50 days. His primary complaints is with the body diagram. We have P1, which is left anterior knee pain, and it was described as intermittent, superficial, achy. The patient also used the term, it's just a weird feeling, but we have pain there ranges from 0 to 1 out of 10. P2 is the right anterior knee. It's also intermittent, superficial, and described as sore, achy again, with the pain of 0 to 1 out of 10. There's no report of numbness or tingling, and relationship between the symptom areas. It's the same symptoms, however, one does not directly affect the other. Some of the structures that can be considered as a source of these symptoms, you have the patellofemoral joint, tibiofemoral joint, and the proximal tibia fibula. Structures which may refer there, we have all the structures of the knee, really: ACL, PCL, MCL, LCL, meniscus, patellar tendon, IT band, also the articular cartilage. Some of the contractile structures in the area, we have all the muscles of the knee: the rectus femoris, vastus lateralis, semitendinosus, semimembranosus, biceps femoris, popliteus, and the gastroc. And some other structures there, we have the nerves that run through and around the knee: the femoral nerve, obturator nerve, and the tibial nerve. For the primary and secondary hypothesis, first hypothesis based on patient report was knee instability. Also, patellar tracking and Osgood Slaughters were all possible hypotheses that I had from seeing the pain diagram. His aggravating and easing factors: for P1, the aggravating factors are walking and running, especially on uneven ground, and the time to onset depends on level of activity. However, the patient could not give specific times of onset or relief. Some of the easing factors are just rest and also wearing a brace during his activities. For P2, the aggravating factors are the same as P1, and the easing factors again are the same as P1, although he does not wear a brace on the right knee. For his history, his sleep and 24-hour pattern, typically there's no pain throughout the day unless momentary aggravated by activity. Other than that, he reports it just, again, kind of feels weird sometimes when flexing and extending the knee, and he does not report any effect on sleeping patterns. The duration of symptoms is currently at 21 days, and the mechanism of injury was he reports he doesn't really remember, but he thinks he rolled his ankle while walking. Progression since current episode, there is currently no change. Significant prior history: he had a right patellar dislocation in 2011, and he had a previous left patellar dislocation in July of 2012, and he reports having gone to physical therapy previously to treat his symptoms here. His medical history, review of symptoms are all unremarkable, nothing there that we really need to address. The red flag screen, there were no red flags, no yellow flags. And for the special questions, diagnostic test imaging, his mother said that he had an MRI which revealed a lengthened patellar tendon. He's currently not taking any medications. For my asterisk signs from the history, I'm going to use the increased pain with walking on uneven ground. And P2 is again the same as P1, so we'll have the same asterisk sign for both of those. So increased pain and instability with walking on uneven ground. My primary and secondary hypothesis are again knee instability, patellar tracking dysfunction, and Osgood-Schlatters. I haven't been able to rule out any of these diagnoses through the history because they all have similar symptoms to what he is describing. As for the SINs, the severity of the condition, I put it as minimal because he still participates in all his activities as long as he braces that left knee. His irritability is also minimal because the pain increases very gradually, but it subsides quickly with rest. Primary nature of the problem is musculoskeletal, and the stage of the disorder is subacute, but there is still some edema from his recent dislocation. And the current stability of the disorder, it's currently stable with mechanical onset as long as we do not aggravate those symptoms. To rule in and out my top 3 hypotheses there, I'll go through a lower quarter screen to just examine the entire lower quarter, and also palpation of specific structures of the knee, and test for the integrity of all the knee ligaments. And I'll also perform a functional squat and step-up test to observe the mechanics of the knee. I wouldn't defer any items for day 1 or for the initial eval because there's no need to. Based on the patient presentation and tolerance, he's able to tolerate all the treatment well. In the physical exam, there were no precautions or contraindications. Posture observation was normal. There were no real deviations noted. For the functional movement analysis, the asterisk sign, I was using the functional squat. And some of the quick screening tests, I'd clear out the lumbar spine, the hips, and the ankles, which were all cleared through the lower quarter screen. Sensory and reflexes were all within normal limits, and also range of motion were all within normal limits with some discomfort with overpressure of the left knee into flexion. With palpation, there was some apprehension with the lateral glide at left patella, and that was quickly relieved when returning the patella to the resting position. There was edema surrounding the left patella, and the left patella was more almost floating, and there's also apprehension with the lateral glide of right patella, although it is less than on the left. In supine with his knee straight, the patella bilaterally sits about 2 to 3 centimeters superior to the actual joint line of the knee. There were no spinal segmental or joint restrictions. And as you see here with the manual muscle testing, his hip abduction and hip flexion were actually the weakest, both bilaterally, and hip extension negative 5 minus, and knee extensions were both 5 out of 5. For his muscle length, he had decreased quadriceps length, and that was just performed with the Thomas test. And also with special tests, the patient had increased internal rotation and adduction with the functional squat and single leg step up. So my primary hypothesis following the physical exam is knee instability secondary to patella alta. And some of my asterisk signs there with the history would be pain with walking on uneven ground, and that's bilaterally. And on the physical exam is pain with functional squat and single leg step test. My prognosis for this patient, so the recovery for this patient is good, although it may simply be strengthening, stabilizing, and lengthening of those muscles in order to support the knee and the patella, the knee joint and the patella. However, the patient should have a full recovery to previous function prior to the latest onset of symptoms. Time frame recovery is approximately 6 to 8 weeks, and we'll be seeing this patient 2 times a week. And some of our goals for physical therapy are to increase stability of the knee, lengthen quadriceps muscle to allow the patella to drop down a little bit so it can have the proper tracking, and also to decrease pain with activity. As for when this patient's ready for discharge, let's say when he has no discomfort with functional squat, step-ups, and he's also demonstrated the ability to maintain a home exercise program for increasing the stability of the knee and also maintaining the gains that we're able to make through therapy. If he stops making progress, I'd say we probably want to see him still for 3 to 4 weeks. That's twice a week. And if he doesn't have any results for those 3 to 4 weeks with changes to the treatment regime, I would say that it would be probably time for a discharge. And our overall treatment management strategy will be manual therapy and exercise aimed at increasing dynamic stability of the knee, and also to increase the quadriceps length. And this will be performed through office visits and also through a home exercise program. And this will continue for about 3 to 5 weeks until a more advanced and functional program may be established with decreased risk of redislocation. And we will also encourage hip strengthening and stability along with those, just to aid in the stability of the knee. And that is my presentation, and thanks for listening.